Usually when we talk about a medical diagnosis, there's this expectation of precision. It kind of feels like engineering. Like you break your arm, the X-ray shows that jagged white line, and the doctor just points to the screen and says, "There it is. That is the problem."
Right, yeah. The clinical picture is completely binary in those situations. I
Hmm.
mean, it's broken or it's not broken.
Hmm.
And as frightening as an injury can be, that definitive boundary is actually deeply comforting to a patient. We
Yeah.
naturally want things to be, visible and perfectly categorized.
Exactly. But then you step into the world of autoimmune and fibrotic skin conditions, and suddenly that X-ray machine is just
Oh,
useless.
completely useless.
Yeah, we're looking at a diagnostic landscape that is just incredibly murky. You or a loved one gets a diagnosis from a dermatologist, you go home, you open up a search engine, and suddenly you're drowning in terrifying medical jargon.
It's the absolute definition of diagnostic muddy waters.
Hmm.
I mean, when diseases share naming conventions, especially terms related to scarring or tissue hardening,
Hmm.
the anxiety that produces for a patient reading at home is immense
Yeah.
and completely understandable.
That anxiety is exactly why you might be joining us for this deep dive today. Whether you're navigating a personal diagnosis, maybe helping a family member advocate for themselves on a really difficult health journey, or you simply possess a deep curiosity for how the human body works, we're glad you're here.
Definitely.
Today, our specific mission is to answer one highly specific, highly stress-inducing question. Is there an association between lichen sclerosis and systemic sclerosis, which is also widely known as scleroderma?
It's a question that understandably plagues a lot of patients. When the names overlap so heavily, the mind just naturally jumps to the worst case scenario.
Right. And to get to the bottom of this, we've got a massive stack of sources on the table today. We are pulling from the British Association of Dermatologists guidelines, peer-reviewed articles from the Acta Dermatovenerologica journal.
A great journal, by the way.
Yeah, really solid. And we also have comprehensive medical texts on scleroderma mimics and some really revealing case control studies. Okay, let's unpack this by first defining the two complex conditions at the center of our deep dive. Because before we can see if these two conditions are linked, we have to establish what they actually are. And the terminology here is just notoriously confusing.
It really is.
Mhm.
So let's start with lichen sclerosus, which is often abbreviated as LS. At its core, LS is a chronic inflammatory dermatosis.
Meaning a skin condition, right?
Right. It's an autoimmune condition where the immune system loses its sense of self-tolerance. So instead of fighting off external viruses or bacteria, the immune system inappropriately targets the patient's own healthy skin. And that leads to severe chronic inflammation.
And when we look at the data, this condition has a very specific primary battleground.
It does, yeah. While it can theoretically appear anywhere on the body, about 85% of cases occur in the anogenital region.
Wow, 85%.
Yeah, it's significant. And it predominantly affects women with two distinct peak ages of presentation prepubertal girls and postmenopausal women. Though, I mean, to be clear, it certainly affects men and children as well.
Right.
Clinically, it presents as these very distinct porcelain white plaques on the skin.
I want to make sure we don't understate the severity here because, we aren't just talking about dry or mildly irritated
Oh,
skins.
not at all, no. The hallmark symptoms are intense, unrelenting itching and pain. Patients also frequently report dysesthesia, which essentially means any normal touch feels abnormal or even downright painful.
That sounds awful.
It is. But perhaps the most distressing physical aspect is the architectural scarring it causes. As that chronic inflammation persists, the skin loses its natural elasticity and becomes incredibly fragile. I mean, it can fissure or tear with just basic movement.
And that structural damage obviously leads to massive functional issues.
Yes, absolutely. In women, this can lead to the fusion of the labia minor, or the burying of the clitoris under scar tissue. In men, it frequently causes severe phimosis, which is a condition where the foreskin becomes so heavily scarred it just cannot be retracted.
So the impact on a person's quality of life, their sexual function, even their basic ability to use the bathroom without pain, I mean, it's profound.
It's life-altering.
And the guidelines note a darker complication if this chronic inflammation is left unmanaged, right?
That is a really critical point. There is an increased risk of squamous cell carcinoma, a type of skin cancer, developing in those chronically inflamed genital tissues if LS is left untreated over the long term. So while it is primarily a localized disease restricted to the skin and mucosa, its impact is undoubtedly severe for the patient.
Okay, so that is lichen sclerosis. We're dealing with a severe localized inflammatory attack. Now, if we shift gears to the other sound-alike condition, systemic sclerosis, what happens when an autoimmune disease forgets those localized boundaries entirely?
Well, that is when you enter a completely different diagnostic category. Systemic sclerosis, which people often broadly refer to as scleroderma, is a rare, severe autoimmune condition. We're talking about a prevalence of maybe 31 to 100 people per million.
Okay, so very rare.
Very rare. In systemic sclerosis, the immune system doesn't just cause localized surface inflammation, it attacks the connective tissue itself, causing the body to massively overproduce collagen.
When I think of collagen, my mind immediately goes to the supplements people put in their morning smoothies to prevent wrinkles. It's supposed to be like the building block of plump, healthy skin.
Right, yeah, you've got the right idea with the smoothie collagen.
Mhm.
But imagine that cellular manufacturing process stuck in catastrophic overdrive. The body is essentially churning out so much of this structural protein that the skin and tissues become incredibly thick, hard, and scarred.
Wow.
And systemic sclerosis is generally divided into two main forms, limited and diffuse.
What's the difference there?
The limited form often starts with Raynaud's phenomenon. That's where blood vessels spasm and the fingers turn stark white or blue in the cold. And that comes along with hard lumps of calcium forming under the skin. The diffuse form, on the other hand, involves rapid skin thickening that spreads aggressively across the body.
Gosh, it sounds less like a skin condition and more like the body's internal repair crew going completely rogue.
That's exactly what it is.
If lichen sclerosus is like a severe surface level storm damaging a very specific part of the landscape, systemic sclerosis is like a deep systemic earthquake that actually alters the foundations and internal plumbing of the entire body. It's pouring concrete, which in this case is the collagen everywhere, indiscriminately, until the gears of the organs literally get stuck in the cement.
That is a highly accurate way to visualize the mechanism at play. The word systemic is the defining feature here. Systemic sclerosis causes fibrosis, this dense, scarring overgrowth of tissue inside the internal organs.
Not just the skin.
Right. It attacks the lungs, leading to interstitial lung disease, which drastically reduces oxygen capacity. It affects the heart, the gastrointestinal tract, the kidneys.
Yeah.
Because it turns flexible internal organs into stiff, non-functional scar tissue, it carries a very high mortality rate.
So if LS is a surface storm and systemic sclerosis is an internal earthquake, why is there so much medical confusion linking them? Why do patients panic when they see the word sclerosis on their pathology report?
The answer lies in a third condition, a condition that acts as a sort of visual and diagnostic bridge between the two. It's called morphia, which is also known clinically as localized scleroderma.
Localized scleroderma. Okay, how does this third condition bridge the gap between the surface plaques of LS and the internal fibrosis of systemic sclerosis?
Remember how we noted earlier that 85% of lichen sclerosis cases are in the genital region? Well, about 15% of cases are extragenital. This means the LS plaques appear on the neck, the back, the shoulders, or the wrists. And when LS appears in these extragenital locations, it looks incredibly similar to morphia. Both present as these ivory white plaques, often with a tightly drawn, parchment-like skin texture.
So to the naked eye, even to a trained physician doing a standard exam, they can look like twins.
Exactly. And what's fascinating here is just how closely these diseases intermingle at a biological level. It goes far beyond just looking visually similar in a clinic. The scientific literature tells us that up to 5% of patients diagnosed with morphia actually have coexistent lichen sclerosis within the exact same lesion.
Wait, really? In the exact same spot?
Yes, you can literally have the pathology of both diseases sitting right on top of each other on the same 1-inch patch of skin.
I imagine if they overlap so perfectly, telling them apart requires going much deeper than a visual exam. How do doctors even tell them apart if they are sharing the same real estate?
It requires intense microscopic detective work. Doctors rely on histopathology, which involves taking a biopsy of the tissue and looking at the cellular structure under a microscope, and dermoscopy.
What's dermoscopy again?
It uses a specialized, highly magnified, polarized light tool directly on the patient's skin. And when you look closely at the architecture, the damage with these tools, the mechanisms start to diverge.
Because they are fundamentally attacking different layers of the skin's architecture, right?
That is the key differentiator. Lichen sclerosis primarily shows changes in the superficial dermis, that's the papillary layer, right under the very surface of your skin.
Okay.
Under the microscope, you see epidermal atrophy. meaning that topmost layer of skin is dangerously thinned out. You see a loss of the elastic fibers that give skin its stretch, and you see these keratotic follicular plugs. They look like little pseudocomedones or blackheads when viewed under the dermatoscope.
And where is morphea doing its damage?
Morphea does its damage much deeper down. It affects the reticular dermis and occasionally extends into the subcutaneous fat tissues. Under the microscope, instead of thinning, you see massively thickened, dense collagen bundles. On a dermatoscope, instead of those little surface plugs, you see what dermatologists call white fibrotic beams.
Fibrotic beams.
Yeah, they are deeper, much more opaque, structureless white areas reflecting the dense scarring underneath.
This raises a really important structural question, though. If they can exist in the exact same lesion, and one affects the top layer while the other affects the bottom layer, are they actually just the same disease presenting on a vertical spectrum?
You have just touched on one of the great ongoing debates in the dermatological literature. Some researchers genuinely believe lichen sclerosus is literally just a localized subtype of morphea. They even propose abandoning the name LS entirely for these lesions and reclassifying it as subepidermal morphea.
Wow, that would certainly upend the diagnostic textbooks.
It really would. However, others vehemently insist they are distinct, separate diseases that just happen to share certain pathophysiological pathways and inflammatory triggers.
Right.
Because their mechanisms overlap, they occasionally show up at the exact same anatomical party, but they maintain distinct identities.
Okay, so knowing that lichen sclerosus and localized scleroderma morphea are so strongly linked and debated, we have to answer the core question that brought you to this deep dive. Does having lichen sclerosus mean you are at an increased risk for the severe organ-threatening systemic sclerosis? Like, if you have the localized surface issue, are you destined for the systemic concrete pore?
Fortunately, we have very robust peer-reviewed data to answer this. Let's look at a highly specific 2021 case control study by Hieta and colleagues out of Finland. It was published in the Acta Dermatovenerologica. They looked at a cohort of 455 female patients diagnosed with lichen sclerosus.
And what did the data reveal about their long-term outcomes?
First, the researchers confirmed the morphea link we just discussed. Out of those 455 women, 1.3% had morphea. Now, that percentage might sound small out of context, but statistically, it represents a relative risk that is 60 times higher than the general population. So the link between LS and localized skin hardening is undeniable.
But what about the systemic internal version? Did the superficial inflammation cascade into internal organ damage for these women?
Zero.
Oh.
Out of the 455 patients with lichen sclerosus, exactly zero had systemic sclerosis. The data provides immense reassurance on that front.
Oh, wow. I imagine that is a massive sigh of relief for anyone listening who is spiraling after a recent diagnosis. But hold on, I want to look at this from another angle because there's a twist in the research stack we have here.
Oh, yes.
The Finnish study looked at people who started with LS. But what if we reverse the timeline?
You are referring to the 2018 study by Gousseau and colleagues out of France.
Exactly that one. They examined 79 patients who already had a confirmed diagnosis of systemic sclerosis. And out of those 79 patients, 8% had genital lichen sclerosis. Specifically, it was women who had the limited cutaneous form of systemic sclerosis. So the Finnish study says LS patients do not go on to develop systemic sclerosis, but the French study says systemic sclerosis patients do develop LS. How do we synthesize that apparent contradiction for the listener?
It definitely seems contradictory at first glance, but it actually makes perfect immunological sense when you look at how the body's defense systems fail.
Let me see if I can work through the logic here. It feels like a squares and rectangles situation. A square is a rectangle, but a rectangle is not a square. The data suggests that if you have systemic sclerosis, this severe, rare condition affecting the internal organs, you have a highly overactive, deeply chaotic immune system.
Yeah.
That underlying systemic chaos might increase your likelihood of also developing the localized surface inflammation of LS.
Yes.
But if you have LS, which is vastly more common, the data does not show that you are at an increased risk of developing systemic sclerosis.
That is a brilliant logical summary of the data. If we connect this to the bigger picture, you are describing a very well-documented phenomenon in immunology called autoimmune clustering.
Autoimmune clustering, can you walk us through the mechanics of that?
Sure. When a patient develops one autoimmune disease, their immune system has already proven that it has a fundamental propensity to make errors, specifically, to identify the body's own self as a dangerous enemy.
Right. The system is already glitching.
Exactly. Once that threshold is crossed, it makes the patient slightly more prone to developing a second, distinct autoimmune disease. We see this all the time in clinical practice. For example, patients with lichen sclerosus have a significantly higher, well-documented rate of autoimmune thyroid disease compared to the general public.
So having a chaotic immune system that causes systemic sclerosis might make you prone to developing LS, just like having LS makes you prone to developing a thyroid issue. The immune system is just generally confused.
The underlying vulnerability is shared. But, and this is the crucial takeaway for the patient listening at home, autoimmune clustering is not a guaranteed cascade. It is not destiny. Having an autoimmune disease in your skin does not mean your internal organs are automatically next in line to be attacked.
I find that distinction incredibly empowering for anyone dealing with the mental weight of a chronic illness. Okay, so we've established that while they are related through this autoimmune cousin called morphia, they are distinctly different threats.
Yes.
But because these diseases share this autoimmune phenotype, this fundamental tendency toward fibrotic scarring, they naturally share treatment pathways. We need to explore how modern medicine actually fights back against these conditions.
The treatments overlap significantly because the underlying mechanism, a rogue immune response driving tissue scarring, is structurally similar. For lichen sclerosus, the absolute gold standard first-line treatment is the application of superpotent topical corticosteroids.
And it is worth noting, the dermatological guidelines stress that adhering to these superpotent steroids long-term actually reduces the risk of that squamous cell carcinoma we talked about earlier. It halts the chronic inflammation that causes the cellular damage before it can mutate into cancer.
The clinical goal is to aggressively shut down the localized friendly fire. Now, for recalcitrant cases of extragenital LS that don't respond to creams, or for the deep skin hardening seen in systemic sclerosis, doctors often turn to more intensive interventions.
I imagine if the inflammation is that deep in the reticular dermis, standard topical creams simply won't penetrate. What can doctors actually use to reach that deep into the tissue?
Phototherapy is a major tool here, specifically UVA1 and PUVA therapies. And to be clear, these aren't just commercial tanning beds. These are highly specific, medically calibrated wavelengths of ultraviolet light that penetrate deep into the dermis.
And what does the light do?
Once the light reaches those depths, it actually induces apoptosis in the hyperactive T cells that are causing the inflammation.
So the light therapy is essentially triggering a programmed self-destruct sequence in the specific rogue immune cells causing the damage. That is incredible. And they also use systemic drugs for the really tough cases, right?
Yes. Immunosuppressants like methotrexate are used for both severe extragenital LS and systemic sclerosis.
But how do these treatments actually know what to target? When I looked at the sources, it seems scientists found the exact mechanisms the immune system is targeting in both diseases.
They have isolated the specific autoantibodies. In lichen sclerosis, research shows that about 80% of patients have autoantibodies actively attacking a specific protein called extracellular matrix protein 1, or ECM1.
ECM1, okay.
This protein acts like the biological glue supposed to hold the skin together and regulate collagen production. When ECM1 gets continuously attacked, the skin loses its integrity and turns into that white, scarred plaque. In systemic sclerosis, the immune system uses different weapons, entirely specific autoantibodies, like ANA, which stands for anti-nuclear antibodies.
Meaning they attack the nucleus.
Exactly. They are rogue proteins attacking the actual nucleus of your healthy cells. Or they use anti-CL70.
But regardless of whether the immune system is using the ECM1 weapon to attack the skin's glue in LS, or the anti-nuclear weapon for systemic sclerosis, the treatments, the superpotent steroids, the self-destruct light therapy, the methotrexate, they all work by walking onto the cellular battlefield and forcing the immune system to put its weapons down.
That's spot on. The clinical objective across all these treatments is to aggressively dial down the friendly fire, regardless of which specific antibody is leading the charge.
Here's where it gets really interesting, though, because while we have these massive technologically advanced medical interventions, calibrated light therapy, targeted immunosuppressants, the sources highlight a surprising treatment intervention that is almost shockingly simple.
You were talking about addressing the Koebner phenomenon.
Yes. Can you explain the biological mechanism of the Koebner phenomenon? Because understanding this feels like giving patients a tremendous amount of control back.
The Koebner phenomenon is a fascinating physiological process where new lesions of a pre-existing skin disease appear exactly along lines of physical trauma.
Wait, literally along the line of an injury?
Literally.
Yeah.
If you have an active autoimmune skin condition, your immune system is already on high alert. If you scratch yourself, or your clothing rubs a specific area raw, the immune system rushes to that site to heal the minor injury. But because the immune system's signaling is fundamentally confused, instead of building healthy new skin, it accidentally builds a brand new plaque of disease. The lesion literally traces the physical path of the injury.
So the repair mechanism is broken, and every time it tries to fix a tiny scratch, it just lays down more diseased tissue.
Yes.
And the sources point out that in genital lichen sclerosis, one of the most common forms of chronic trauma is actually microincontinence.
That's right.
So tiny leaks of urine that sit on the skin, altering its pH, combined with the friction of walking or wearing tight clothing.
It creates a perfect storm for the Koebner phenomena. The microincontinence creates chemical irritation, the clothing creates friction, and the hyperactive immune system rushes in and builds scar tissue in response. And the clinical literature notes that sometimes something as simple as treating the underlying urinary microincontinence or stopping the daily friction with barrier ointments can literally halt the progression of the lichen sclerosis.
Wow.
And you remove the physical trauma, and you remove the environmental trigger for the Koebner phenomenon.
It emphasizes that while these are deeply complex autoimmune diseases driven by autoantibodies and rogue P cells, basic barrier protection and environmental management play a massive, underappreciated role in treatment. It's why understanding your comorbidities is empowering rather than terrifying. Context really is power here.
Absolutely. The more you understand the mechanism, the more agency you have. If you know that lichen sclerosis is associated with autoimmune thyroid disease, which we discussed earlier regarding autoimmune clustering, you don't need to live in fear of a sudden complication.
Right, you just monitor for it.
Exactly. You simply know to ask your primary care doctor to add a routine thyroid blood test to your annual physical. If you understand the Koebner phenomenon, you understand that your skin might react poorly to daily friction, so you adjust your clothing and protect the skin barrier with emollients. Knowledge actively takes the fear out of the diagnosis.
So what does this all mean? Let's bring this all together for you listening today. We unpacked two heavy, terrifyingly similar sounding diagnoses, lichen sclerosis and systemic sclerosis. We learned that while they share an autoimmune phenotype, and while the surface inflammation of LS can closely mimic a localized hardening of the skin called morphea, they are fundamentally distinct conditions.
Completely distinct.
The clinical data provides immense, statistically backed reassurance that a diagnosis of lichen sclerosis does not put you at a high risk for the life-threatening internal organ complications of systemic sclerosis. Having a localized issue on the surface does not mean your internal organs are destined to be turned into concrete.
The epidemiological data is very clear on that point. They may exist in the same broad medical neighborhood of autoimmune disorders, but they are absolutely different houses with different foundations.
But our deep dive into the literature leaves us with a fascinating, lingering thought about how the body interacts with the world.
It does. We know from the medical texts that the severe systemic sclerosis can be triggered by extreme environmental factors, things like chronic occupational exposure to silica dust, vinyl chloride, or heavy organic solvents. And we just discussed how localized lichen sclerosis can be triggered by daily microenvironmental factors, friction, minor chemical exposure from urine, or physical trauma through the Koebner phenomenon.
Which makes you wonder, what if the real secret to these fibrotic diseases isn't just permanently hidden away in our genetics? What if it is intimately tied to how our skin's localized immune system actively remembers and overreacts to the physical world we bump into every single day?
It is a profound immunological question. If our skin genuinely holds an immune memory of trauma, constantly reacting to the microscopic damage of daily life, how much power do we actually have to alter its environment? Can we change the long-term course of an autoimmune disease simply by changing how our skin interacts with the world around us?
It completely flips the script from feeling like a helpless victim of a broken immune system to being an active participant in protecting your body's boundaries. Thank you so much for joining us on this deep dive. We hope unpacking the science today has cleared the diagnostic muddy waters and given you a sense of clarity. Keep exploring the research, keep asking your doctors questions about the mechanics of your health, and always seek multiple perspectives on your journey. Because as we saw today, sometimes that terrifying medical jargon doesn't mean what you think it means.